There we go. We're live.
All right, we're back. We took a short 2-minute stretch. And so now we're back to hear from folks from the Green Mountain Care Board. And this is part 2 of options for regulating provider reimbursement. And you've done a great deal of work to bring us this information. So thank you for being here. And why don't I turn it over to you, Robin, and you can take us through the information.
Great. Well, thank you for having us back for part 2. What we're going to do today is we're going to do a very brief recap, just to reorient you. We know you've had a very busy week since we last saw you and have been thinking about lots of other issues, so we just want to reorient. We're going to talk a little bit about the process and scope of the options, which we did not do last time, and then we're going to go back through the 3 options at a deeper level. This is not the most deep level that we could do, but we'll take your lead on that. We thought maybe a mid-level would be the right for part 2, although happy to do deeper as you prefer. So Elena, could you go to the next slide, please? Thank you. So just to reorient you, this is a report that we did under Act 159, Section 5, where we collaborated with other parties to look at regulation of provider reimbursement, looking at it through several different lenses, including the lens of where we are in today's environment around value-based care, looking at both a provider lens and other regulatory lenses, and also with a focus on sustainability of providers and equity issues in reimbursement. And of course, even though this was not spelled out in the legislation, we also considered consumer affordability. And as we went over last time, all of these different priorities at times do conflict. And so it's really a balancing act that we're trying to figure out the right way to proceed. And so that's a good thing to keep in mind. So next slide, Elena. And so just again, when thinking about these options, it's good for us to be oriented in terms of the key problem that we're trying to solve. Certainly cost containment and value-based care are central to our health reform strategy, but really when we get into the details of regulating reimbursement, how do we prioritize sustainability and reimbursement equity, balancing consumer affordability and access? And of course, defining sustainability and reimbursement equity is also a bit of a challenge because we have quite a broad provider community and there are sustainability issues in a number of different areas. And equity can at times be a little bit in the eye of the beholder. So looking at, again, and thinking through these options in terms of balancing those different competing interests within the provider community. And lastly, when thinking about how to move forward in our reform environment, balancing provider-led reform with mandatory regulation. And in our current regulatory scheme, for example, in our ACO budget process, we have a direct charge to really defer to provider-led reform. And so thinking about how you would like to strike that balance should you decide to move forward. So at this point, I'm going to turn it over to Sarah, I think, to talk to you about how we developed the report and the scope.
Thanks, Robin. So I'm just going to spend a couple of minutes giving you some more background on the report development process before we dig into the policy options. So we developed these options by researching known examples and scanning the literature for regulatory approaches and state examples. And we really tried to capture a range of approaches, including adapting current GMCB regulatory processes and envisioning new regulatory envisioning new regulatory approaches using or expanding on our current authorities. So Act 159 directed the board to engage with the Director of Healthcare Reform at AHS, with DBA and with DFR. And we did so multiple times as we developed the report, including receiving their comments on drafts and reviewing drafts with those state partners. We also got incredibly helpful feedback through this process. We also took the opportunity to share the draft report with potentially regulated entities and advocates in early March and solicited their comments, and that included VAWS, Health First, Bi-State, Blue Cross, MVP, VMS, the Office of the Healthcare Advocate, a member of the public who requested to join. Elena and Robin will tell me if I'm missing anyone. But we really tried to make sure that we were soliciting a broad spectrum of feedback on the report and understanding how these potential options would impact a variety of provider types and payers as well. Next slide, please, Elena. Oh, thank you. So this report could easily have doubled in size and complexity if we had, spent more time on it. But in order to make it, I don't know if I want to call it digestible, but more digestible, and to hit the report deadline, we had to establish some boundary conditions related to provider type, services, and payers. So in subsequent analysis, we could really broaden or clarify the scope if the committee or the General Assembly directed us to do so. But we wanted to outline, who we included and what services and provider types we didn't touch. So the options discussed in the report really focus on regulating reimbursement for hospital inpatient, outpatient, and professional services, so like primary care and specialty services. The report excludes providers for whom Medicaid is the dominant payer, and the example that we give here are DAs, since the state already sets their payment rates and growth rates, and there's significant infrastructure and expertise at DBA and other AHS departments that oversees these providers. The report also excludes pharmacy, dental, and vision, just because it adds a whole lot of complexity. As we discussed last week, the federal laws around reimbursement of FQHCs really complicate inclusion of FQHCs in these potential regulatory models. And that doesn't mean that they could not work for FQHCs or that we couldn't include FQHCs, but it would take a lot more exploration and analysis to kind of assess whether there's potential there. All right, next slide, please. Thank you. So we also want to note that we really focused on options that impact reimbursement from Medicare, Medicaid, and the fully insured commercial health plans in the individual, small group, and large group markets. We're not looking at other segments of the commercial market like Medicare Advantage, workers' comp, federal employee health plan, or TRICARE, which covers members of the military. And we'd need to do much more research for each option to determine how it would impact those market segments. I think now I'm going to pass it on to Elena.
Hey, go to the next slide. So I won't spend too much time because we went through this in part one, but just a couple of reminders of how we approach the report as we dig into some of the policy options. So again, we outlined an array of options, not necessarily recommendations. I think to get to recommendations, we would need to further refine kind of the policy priorities and goals. But I think this gives you a broad range, as we mentioned before, of options to look at. And then with that further refinement, we could kind of hone in on the different policy options, cost estimates, and think about what other kind of intersections there are with federal permissions that may be necessary. And we'll try to point to those as we discuss the options in more detail. And in practice, there may be tensions between the goals of sustainability, equity, or reimbursement equity, to be clear, cost containment, the shift to value-based care, affordability, and access. So no single option maximizes these goals, but as we discussed, an approach could be pursued in which you would layer one or more of these options, and that might cover a broader breadth of these policy goals. Again, but there is this dynamic of complexity and expense that should be considered. So I think with that further prioritization of policy objectives, we can kind of get clearer and perhaps kind of pair some of these options more appropriately. So the three high-level kind of categories of policy options we introduced briefly last time, but we'll dig into more today, are health systems budgets, setting reimbursement parameters, and fee-for-service rate setting. And I think where the discussion landed after part one was really a focus on options 1 and 2 as kind of more amenable to kind of the value-based care context, but how can we kind of think about all three of these options and leverage some lessons learned to talk about the different policy objectives. So I'll start by digging in a little bit to the health system's budget. So we define this as caps on spending for some portion of the healthcare system. So it could be for a provider organization, a facility, or for a network of providers. These health system budgets are generally set prospectively with a defined budget amount, a prescribed enforcement mechanism, and a prescribed payment methodology. So we'll talk about some examples, but in Maryland, the prescribed payment methodology really relies on fee for service. Whereas in Pennsylvania, the prescribed payment methodology is really on a per person payer level. So it's more akin to our attribution fixed payments for attributed lives in the ACO world. But budgets can be all payer or payer specific, but the option is intended to impact kind of total spending and is more of an aggregate level of approach with some options to refine and kind of control the mechanisms by which providers are paid within there. So there are three potential regulatory approaches to this option, or different ways you could implement a health system budget. You could implement it from the provider side through an ACO or from the insurer side. So what could this approach help us tackle? What kind of challenges could it help us address? So the unit cost, utilization, and value-based payment, it's amenable to that approach. And I think both Pennsylvania and Maryland have a value-based lens in different ways, but both value-based in nature. It also, depending on the methodology, the payment methodology can really help you facilitate, unit cost and utilization challenges. It does also help with the sustainability concern. Pennsylvania established their model specifically to address rural hospital sustainability because it allows some predictable and flexible funding to otherwise, very volatile volume-based environments. So, and it also helps address cost containment, which is how Maryland is really using it to hold the line at an aggregate level. And then the impact of minimal reimbursement increases on public payers. So you can really look at kind of the relative contribution by payer to a particular facility or provider by what issues are hard to address with this approach? It's a real challenge for market power for smaller and currently unregulated providers. So I think, not to say that it could not extend that far, but I think we had difficulty thinking about how that could look in a realistic and kind of expense conscious fashion. And not to say it couldn't be done, but perhaps someone else can help pick up where we left off. The cost estimates are there for you to look at. I think it makes more sense relative to the other approaches, but it is not a light touch. But if I think most of that is on the front end, and then you have to really think about what savings you may achieve over what period of time makes sense. Yeah.
When you're talking about cost estimate, wow, there's an echo. Sorry, well, but when you're talking about the cost estimate ranges for implementation, can you talk just really briefly about what you're suggesting for implementation versus ongoing operations? That would be helpful.
Sure, and we can do that later on if that's helpful. Or I think implementation is really about design and fleshing out the payment methodology. There's quite a range here because it can be implemented. Each of those regulatory approaches, whether it's provider, ACO, or insurer approach, really prescribes a different series of steps that would need to happen. So I think this, out of all of the options, is I have the largest confidence interval, or very little confidence that these are the right estimates, because it is really, there's a lot of room to further define this option that would help us get clearer. But
Elaine, if you don't mind me just jumping in, I would say the distinction really at the high level is, what do we need to build the system? What do we need to run the system ongoing? And the only thing I would add to what Elena said is that, I think that with this option in particular, there are 2 states that have have done this, Maryland and Pennsylvania, and what we've done in our hospital budget process. So this is really the option where we are trying to come up with a new or a different way of moving forward. So obviously then the implementation costs are going to be higher because there's not an existing model to kind of adapt.
Absolutely. And
Madam Chair, I'm sorry, Elena.
Go ahead.
Well, I just want a clarifying question to what Robin just said. Aren't we sort of doing this a little bit with hospital budgets with the Green Mountain Care Board hospital budget review?
We are. We're doing it a little bit, but and one of my examples for in option 2 is our hospital budget process, because what we're really doing is at a policy level. We do, and I can talk through this in some detail if it would be helpful. I would say the weakness in our current hospital budget process as an actual budget is that our current process doesn't really allow for nuanced enforcement the way these other states have approached it. And so it's really, it would need some substantial overhauling to make it really work like a budget, because the payments don't necessarily follow. The piece it's missing is the payment methodology and a nuanced enforcement mechanism.
Got it. Okay. And so when you say options for option 3 potential regulatory approaches, you say provider, ACO, and insurer, is Green Mountain Care Board an option as well?
So we have assumed in all of these approaches that we are the regulator. So these are the 3 ways that we could implement these options. And on the provider level, if we do want to, when we want to get into the details of these 3 different options, that the example that we've talked about is refining the hospital budget process. And potentially expanding it, although we really focused more on the bigger entities.
Okay, thank you.
yes, okay. So the next 2 slides kind of detail the Maryland and the Pennsylvania approaches. So I'll talk a little bit about each of those, but I think I tried to weave in some of the necessary points earlier. In Maryland, they have a global budget, all payer global budget. And as I mentioned, they rely on a fee-for-service rate setting mechanism. And each of these states has a regulatory board, much like the Green Mountain Care Board, much like different than the Green Mountain Care Board, but regulates these models. And so in the Maryland model, they adjust the fee-for-service rates depending on the utilization that is experienced so that they can plug towards that total global budget for the facility. And then they have a series of hospital facility level quality metrics. They're really focused on ED usage. And so, I think they've seen a lot of success. They've had this for a long time now and have evolved it over the years, but they're actually looking to move away from the fee for service and trying to find ways to do more fixed payment, similar, keeping the global budget concept, but shifting away from fee-for-service, as we've talked about before. In Pennsylvania, they had a little bit of trouble getting it off the ground, but now that they have their board established, I think things are moving a little bit more. And here, it's a different approach. They're starting with the payer side of the equation and then fixing those budgets for a particular facility. They have had trouble getting all commercial payers. So they do, it's still just a portion. It's not truly all payer, but they have seen kind of the value of the fixed payment as well, particularly during COVID, and being able to maintain their rural facilities where they may not have otherwise been able to keep the doors open under a fee-for-service environment. And now I will turn it over to Robin.
Great. And maybe before I start on option 2, it might be helpful to just highlight some of the differences between those 2 models and our hospital budget process. So for example, so Maryland, when they first started, when they were adjusting the fee schedule for utilization, they were doing that on a monthly basis. So it was a very high touch mandatory model for hospitals, and And they also had some weirdnesses that came out of that. So for example, you would go to the hospital for a service in July, and then you would go in August, and the price would be different, right? Because the price goes up and down depending on where utilization is to try and hit that monthly budget. So there are some lessons to be learned from that kind of approach. On the other hand, it was very good at getting them to really a fixed amount of money coming in the door without changing the underlying fee-for-service structure. In Pennsylvania, they've taken a voluntary approach, and so then that's been a little bit different, as Elena said, and it has, as a result, been a little bit slower to grow, which I think is a common feature on any kind of voluntary program in most policy sectors. In the hospital budget process, we really look at the budget for the next year, set a couple different kinds of price and utilization caps, if you will, and then the hospitals and the insurers negotiate within those parameters. We do enforcement in the sense that we look at actuals when we have that information, and then we may adjust either future budgets or future prices depending on the result. But that happens, not in real time, let's just say it that way, right? It happens like a year after you've set the budget or more, because we don't typically get the actuals until a few months after the end of the fiscal year. So there's really a delayed response that you don't see in Maryland. So those are really the things I just wanted to kind of compare and contrast. Anything else, Sarah, Elena, that you think we should compare and contrast before we move to the next? Or Senator Lyons, do you want to pause here for more questions related to option 1?
No, I think we're fine, unless the committee has questions and they know to just speak up, because we can't see everyone on the screen. So I'm not hearing any voices.
Okay.
So we'll go right ahead. Thank you.
Okay, so option 2 is really looking at regulating provider reimbursement at a higher level. So it would really, and it would direct either growth caps or growth floors for services or provider types to align that growth with the state policy goals chosen by the General Assembly. And this option really focuses on growth in unit cost. It doesn't touch the underlying fee-for-service unit costs in year 1. Of course, growth over time will impact that, but it really looks at how you move from where we are today and adjust our payments in reimbursements based on policy choices over time. Again, this can be implemented at the provider level, as higher level service parameters, or at the insurer level, and I'll go through each of those in a little more detail. But the example that we talked about last time was setting a reimbursement parameters where payments for primary care services must increase X% in whatever year. Of course, if you want that to be budget neutral for the commercial premium payer, there would need to be an offsetting limitation in order to maintain the cost containment aspect of ensuring affordability. So this approach can be used to redirect reimbursement growth to prioritize certain providers or certain services and limit growth for other sorts of care. It really does highlight winners and losers in the provider sector. So that's just another thing to note, that it's very clear on which types of services or providers are getting the growth and which are being constrained. It can help, I think, to counterbalance a lack of market power to some degree, but that happens over time, not in sort of one fell swoop like you would do with a fee-for-service rate setting system. It's a little bit harder to look at this in terms of total spending, because it really is targeted on price, not on utilization. However, that's more true in the currently unregulated market. Certainly if you layered this on top of the hospital budget process, for example, that would not be a concern at that level. And then the sustainability of providers is tough to really address with this approach unless they're otherwise regulated. Because again, sustainability, as we talked about last time, is really a provider-specific look at their revenue and their expenses. And so if you're setting these reimbursement parameters at a higher level, you're not taking an individual provider look and saying, yes, a 2% increase is enough to keep this particular provider sustainable. Of course, if you understand some of the challenge of sustainability in the provider community, that these approaches could be tailored for that, but it's just not a very nuanced look at sustainability. The cost estimates for these are a little bit cheaper because you are approaching this regulatory process at really a somewhat higher level, more where you're setting guidelines for the private sector in particular and allowing them to negotiate and work within those parameters. And again, we've split up the cost estimates into what we need to set the system up and then what we need to run it over time. And you'll see there is quite a bit of variation depending on which approach, and we'll do a deeper dive when we get into those sub options. Next slide. So we have two examples that I'm going to go through. The first is our current hospital budget process and how we do it today. And then the Rhode Island affordability standards that we touched on last week. So I know that you did have Susan and Lori in to talk a little bit about hospital finances and probably touched on some of the budget process. So please let me know if I'm going too deep or too high since I wasn't here to hear that testimony. So the hospital budget process has been around since 1983, and it's annually reviews and established the hospital budgets for all 14 hospitals. It looks at local healthcare needs and resources, utilization and quality data, hospital administrative costs and other data, as well as presentations from the hospitals and comments from the members of the public. The board started this process in 2012. The other thing I should mention before I get too deep is that when I'm talking about this, I'm talking about the hospital budget process in a normal non-COVID year. As I'm sure Susan and Lori talked about, both last year and this year, we worked to try and streamline the process and pull it up a level to give some relief to the hospitals who necessarily and understandably need to be focused on COVID and issues related to COVID. So when I'm talking about this is not this year. This is sort of pre-COVID normal run of show, if you will. So the way this works is the hospitals submit their budgets on July 1st for the coming fiscal year, and the hospital fiscal year runs starting in October, which is the federal fiscal year. And that's tied, it was tied originally, I think, to that by the legislature because of Medicare and the way Medicare reimbursement works. The board basically exercises two regulatory levers in this process. The first is growth in net patient revenue and fixed prospective payments. So what that means is when we look at the hospital's budget, they submit a budget where they break out their expected revenue and their expenses, their expected expenses for the next fiscal year. The regulatory lever is done at the net patient revenue level because that is revenue that comes from claims. So that comes from providing money paid from patients coming in the door. Hospitals also receive revenue from other areas, 340B, for example, or other revenue from parking garages or gift shops, cafeterias. Those maybe not so much now given COVID, but in normal years, those are also revenue sources, as are investments. We really regulate at the patient side because our hospital budget process was really designed with a focus on cost containment. We do look at the efficiency of the hospital at the high level, and that's the way that we've started to pull in sustainability, because certainly sustainability and cost containment are levers that need to be balanced. So that's one lever, is the net patient revenue. And so when we do the hospital budgets, we look at each hospital individually. We take into consideration their specific circumstances, their specific requests, and then we will set an NPR cap, essentially, under which they are supposed to live. The second lever is change in charge. The charge, as you may know, is every hospital has to provide a charge list. However, the charge is not the amount that people normally pay. That's the gross amount. And then for the most part, the negotiations between the hospitals and the providers will then negotiate a discount off those charges. But we look at the gross charge level, and that's really a historical artifact from the fact that the hospital budget process, there were some challenges for considering confidential information because it's 100% public process. Now, last summer, you did allow the board to start to think about how to incorporate in these net charges and some of the confidential information. Because of COVID and the streamlining, we have not moved forward with implementing that yet because it just, quite frankly, was not the right time. So that's still on the to-do list as a potential improvement in terms of this process. But then what we would do is we set a gross charge increase, and for services that are set on the gross charge and discounted, that will impact that negotiation and that net reimbursement amount. Those are primarily inpatient and outpatient services. If there's a primary care office, for example, that's affiliated with a hospital, those are typically paid differently on a professional fee schedule. So those are not really impacted with what we currently regulate. So our current process is really an example of how you can set some price limits, in this case on inpatient and outpatient services, and in this example, tailored to a specific entity. So next slide. The other example we wanted to talk through with you is Rhode Island. So Rhode Island has established affordability standards since 2004, and those are those are implemented through their insurance commissioner, who has authority over both premium rate review and market conduct of insurers. So they have a broader authority than the Green Mountain Care Board currently does. And so what Rhode Island has done is they've set up criteria for premium rate review having to do with affordability, and those are focused on expanding and improving primary care infrastructure, spreading the adoption of patient-centered medical homes, supporting their state health information exchange, and working toward comprehensive payment reform across the delivery system. And then most recently, in 2016, they set specific cost and price standards. So they require that insurers spend at least 10.7% of their annual medical spend on primary care, and they limit hospital rate increases so that the average increase at that insurer is no greater than CPI plus 1.
Robin.
So, yeah.
Go finish the so.
Okay, so really what Rhode Island has done is use these standards as a way to constrain, direct price growth in an insurance-based system. So it only applies to the insured population in Rhode Island. In Vermont, that's about 95,000 people. And in our authority at the Green Mountain Care Board, while we do have authority over premium rate review, and we do consider affordability when approving a rate, we do not have the authority to set these kinds of ranges or conditions on premiums the way that Rhode Island does. So we do have a look at affordability, and we have used that to really think about how to approve rates that are as tight as possible, really, within an actuarial framework of not too much and not too little. But we don't have the kind of broad authority that they do in Rhode Island.
So you're talking only about privately insured, if it were Vermonters, the 90-some thousand privately insured. And so this, so it's not inclusive of Medicaid.
No, in Rhode Island, it just applies to commercial insurance. It's not inclusive of Medicaid or Medicare or the self-insured population.
Okay. But in Vermont, our all-payer model does have a waiver to include Medicare, but not for the,
Yes,
yeah,
but-
okay.
yes,
That's
to
different.
establish a Medicare ACO program. So
Right.
I think, and one of the requirements of any Medicare waiver is that you have to show that what you're proposing will save Medicare money. So I think, and certainly their interest right now is really on payment and delivery system reform. And so you could potentially think about how to include some of this kind of reimbursement shifts, but it does get a little more complicated with Medicare because of the waiver authority and being able to show that it saves money.
I just wanted to clarify that. Thank you.
Yes. I should say in our hospital budget process, what we do now, the change in charge does apply primarily to commercial insurers. So neither Medicaid nor Medicare base their reimbursements on charges in the way that commercial insurance does. So what we typically do in the process is we ask the hospitals to identify their assumptions in their budget around Medicare and Medicaid increases. And with Medicaid, we usually check in with DVHA's payment reform. And if they've finished their rate setting for the year, we can kind of cross-check that to make sure that the assumptions are in the ballpark of what Medicaid is actually doing. With Medicare, it's more of a, getting an update on what Medicare payment policy is for that year, if it's available. So we do consider that, but quite frankly, those are fixed and outside of our jurisdiction. So really what our authority allows us to do is impact commercial prices and total spending.
Senator Lyons, could I ask a question, please? It's Cheryl.
Yeah, no, go ahead. Go right ahead.
Thank you. Robin, do you have an idea of, what percentage of the population in Rhode Island is covered under this as far as, being just private insurance, and what kind of an effect it's had on the...
Yeah, I don't have that number handy, but we can certainly get that for you because we did ask that question of Rhode Island. And so I apologize that I didn't think to have it handy, but we'll get back to you with that. What we heard in conversations with Rhode Island is that while it does just apply to the insured sector, that they have seen a little bit of spillover effect into the self-insured sector, meaning that because some of the same insurers have both insured business and act as a third-party administrator for self-insured employers, that if they have one fee schedule, then you might see some spillover. But in terms of their exact population, I do think it's more than ours, but we need to get back to you on exactly how much of the population is.
Thank you.
Unless Sarah or Elena can remember.
I don't know the answer to that, but what I will say, and this is slightly old information from my previous life, but I'll just say, so in my pre-Vermont life, I worked on an evaluation of one of the Rhode Island programs that grew out of this, of their patient-centered medical home program. And what they had seen at that time, this is about 2014, from their affordability standards, was that it really had increased investment in the patient-centered medical home program, so their kind of blueprint for health equivalent in Rhode Island. It had increased investment in their state's health information exchange, and they saw their primary care spend increase significantly, over time. Again, this is old info and definitely before the 2016 update to the standards. But that was kind of the early indication, was that at least it was increasing investment in those particular services.
All right, any other questions for me? And otherwise, I'll turn it over to Sarah.
All right, thanks, Elena. So I'm going to talk through the fee-for-service rate setting option. In this option, the regulator sets the reimbursement amount for each service or procedure at the code level. And the example that we provide here is, evaluation and management code X is paid at $100. the other example we could have provided, and I think what's most often done in practice, is that this approach uses an existing payer's reimbursement scheme as a point of reference, and that's most commonly Medicare. So Medicare is really the go-to here, because its reimbursement amounts and methodologies are publicly available, they're national, and they're geographically adjusted. And one of the things we talk about in much greater detail in the report itself is the option to kind of modify some of the details of Medicare's payment methodologies. For example, site-specific payments, which I know has been a conversation in Vermont for many years. So, if we go back to that equation slide that we had in the background, this option is really targeting unit cost, but it doesn't target utilization, which limits its effectiveness in impacting total cost of providing care. So it would really modify, current unit cost and also growth trends, since you'd also be, setting those unit costs over time. Like the other options, there are kind of two implementation sub options, one to implement via provider regulation and the other to implement via insurance regulation. And one of the things that I wanted to point out that was coming up as Robin was talking, and we had talked about this when we did the part 1 presentation last week, the different regulatory options are going to impact different populations. So implementation via insurance regulation, which is kind of the Rhode Island style model for option 2, will only impact that kind of like fully insured commercial market. Implementation via provider regulation across any of the options, has the potential to hit a bigger population, although there are still challenges to including the other payers. But I just wanted to highlight that, we can go back to that regulatory approaches slide and kind of like see some of that balance again, because that carries across all the options, not to make it too confusing. So back to fee-for-service rate setting, the benefit of this approach is really that it sets an equal playing field across all providers of a service, balancing out those market power concerns that typically can be a driver of fee-for-service rates now, and which Robin had alluded to earlier. That said, there are also some issues that are hard to address with this option. It really focuses on unit cost, which we know from other states' experience won't necessarily control total healthcare spending, especially in the long term. It also can't take a nuanced look at sustainability, since it doesn't consider the individual provider organizations, cost, population, payer mix, et cetera. It's not in line with Vermont and the federal government's move toward value-based care and away from fee-for-service reimbursement. And finally, again, as Robin alluded to earlier, there are going to be clear winners and losers in the provider sector. If we're increasing payment for one service type, we have to reduce payment somewhere else.
Sarah, your computer muted you, which is a problem I was having.
She's good.
Can you hear me now?
Yeah.
Oh, good. Okay. Sorry, that has happened to me a couple of times on Zoom. All right. Well, where did I leave off?
You were talking about moving to value-based care and how.
Oh, right. Yeah. Great. Thank you so much. I'm so sorry about that. So finally, there are going to be winners and losers in the provider sector, just like Robin alluded to earlier. If we're increasing payment for one service type, we've got to reduce payment somewhere else, or we'll see healthcare costs overall and premiums rising as a result. Finally, I want to point out that this is a fairly expensive option, with costs of about $600,000 to over $2 million to implement, and ongoing costs estimated between $300,000 and nearly $1 million as well. And that's because it's fairly high touch. It's extremely high touch, actually, in terms of the work required to set up the system and kind of do the ongoing maintenance. We didn't include an example slide for fee-for-service rate setting because it sounded like there was a little bit less interest in this option in our last meeting, and also because it's a little bit more straightforward. But I was thinking maybe I would just talk through one right now. Fee-for-service rate setting was extremely common in states all around the country. I think like more than half of states nationally did fee-for-service, especially hospital rate setting, starting in like the 1970s and through the 1990s, and it kind of fell out of favor. The most long-standing example was Maryland, which did all-payer hospital rate setting, which is all-payer hospital rate setting starting in the 1970s and ending, I think, in 2013 or 2014 when they transitioned to their all-payer global budget model that Elena described. And one of the things that I want to highlight about that is that, you know, Maryland saw the costs per hospital admission becoming constrained, and kind of saved money in the short term. Longer term, the number of admissions increased faster than the rest of the country, so they kind of saw those gains balanced out. And I think that just highlights the you know, that balancing act in the equation between you know, controlling unit cost, controlling utilization, and finally getting to kind of some cost containment. So that is all for fee-for-service rate setting.
A quick question
No,
on that is that Colorado's went through and did a whole code analysis. Is that still ongoing? Is that fee for service? You don't have to, if it's a longer answer, then we have time. It's just I'll just ask.
I'm not sure I know the specific example that you're referring to. We included a Colorado example under option 2 because Colorado has done some study or some significant study about how to implement a more kind of like you know, reimbursement. Now I can't remember what we call option 2. Setting reimbursement parameters for their hospitals through their commercial market as they seek to explore a commercial insurance-based public option. And they've done a lot of analysis there on the different reimbursement rates and kind of gamed out how they would set the reimbursement caps for different hospitals.
Okay, keep going.
I can both hear and talk now. Sorry about that, Sarah. My speaker's cut out. So it was all me. My apologies. So I think really what we wanted to do now is pause because we felt like we wanted to do sort of the medium level and then have a conversation about whether you want to do a deeper dive into any of the options and kind of start to go through some of those sub options for actual implementation, or what your pleasure is.
Well, you know, with 1 minute to go, we probably can't do anything at this point, but the questions that you have asked about what problem are we trying to solve, those are really excellent questions. I think the concern that we hear from our constituents is that it just costs too much and we need to have it be much more affordable and more accessible in certain parts of the state. So those two questions are very powerful questions from our constituents. At the same time, we're hearing from our providers about, and we're seeing the lack of sustainability because of the payment options that currently exist. So I'm not sure we're going to answer any of these questions at this point, but I think that it's and then the last question you have about provider-led reform, I think is really important. It's laudable when providers dive into improve quality outcomes that we're seeing. I mean, you can't have value-based improvement without value outcome, without the outcomes that we care, clinical outcomes. So, and I think there's a sense right now that there are inequities in the system, whether we have value-based payments or not. So, you know, so it's that unevenness that is felt both at the consumer level, the patient level, and at the provider level. So the questions you've asked are really, I think, generate a lot of thought on our part. And I think we should give our committee an opportunity, maybe with you in the room, I'm thinking another Zoom opportunity to have a conversation, if you can do that.
Sure, we'd be happy to do that.
Good, because we're going to be taking up some interests in affordability and accessibility, and we would look to you to help guide some of our discussion and help us through where we are now, and that includes with the ACO and our our waiver. So we're hearing again from Ina Backus next week on the next gen. So after that, we'll have to come back to this. Does that make sense to you?
Absolutely. That sounds like a good path forward.
All right, good. All right.
Madam
Committee-
Chair?
Yeah, questions?
Yeah, can we take down the slides so we can see everyone? Thank you.
Oh, I like them up.
I like to see the people I'm talking to if possible. I think I said this last time, I'm most interested in the first two options, given the drawbacks of the fee for service model and our attempts to get away from it over the last few years. And I mean, it seems to me that because of the pluses and minuses of option one and option two, some kind of hybrid of the two might be a possible approach, maybe bringing in some other ideas, I don't know. But so that's something I would like to explore more with you all. And it's really helpful to have you in the room for this conversation or in the Zoom room. And the other thing I just don't quite understand is do we have a deadline by which we need to make some kind of decision? I know that there's our waiver renewal or reapplication is coming up December 31st, I believe. And I'm just wondering, do we need to make some kind of decision as a legislature now before we adjourn in May, or is there more time? So do any of you have an answer to that?
Sure. I mean, I'm happy to take it unless you want to, Elena.
Go for it.
This is why I get paid the big bucks to answer the hard questions. I think that I think that there's a couple different ways to think about it. To the extent that you want to influence at the high level the direction of the Medicare component of any program, then having some high level guidance on your priorities in that process would be helpful before we move forward with negotiations, which would mean sooner than later.
Okay.
Because in theory, at least, we're going to submit a proposal by the end of the year or not. And then if we do, then that's the start of the process. That's not the end, that's the start. However, you could also think about this as an incremental approach in terms of taking your time to really kind of come up with the type of system that you want, which could start kind of where we are now, and that would give you more time to move forward. I think with any federal negotiation, the challenge for you all is that the negotiation largely happens outside of your purview. It is a challenging process because of this expectation on the federal side that the negotiations do not happen in public. Certainly any public input, that has to happen at different places in the process and certainly before any decisions are made. But it's not, the federal government will not negotiate in public, and quite frankly, it's not necessarily in the state's interest to do that either, because it is a negotiation. So you need to have some strategic thinking about it.
And sorry to interrupt, but is it the Green Mountain Care Board or DEVA, or who is the one who submits the application and does the negotiating?
Yeah, so let me talk about that in two parts. In the last negotiation, which I was part of, it was a joint effort between the governor's office, AHS, and the Green Mountain Care Board. And the board at that time was handling a lot of the public process, in part because the board as an entity needs to have that kind of public process. But the governor the governor and the board were aligned in terms of the goals to be pursued. As part of that agreement, then the actual written document that needs to be submitted to the federal government is required to come from the board under the existing agreement. However, I think in this round, what we've been talking to AHS about them taking the lead on developing the public process, as well as sort of setting the direction. I think this is a statewide model. So you really do need leadership from the executive branch and the governor's office in order for it to really be a comprehensive approach. So I would expect that the board will continue to be involved in that, because quite frankly, if you look at the other state options of Maryland and Pennsylvania, in Pennsylvania, they required Pennsylvania to create a regulatory board. So the federal government isn't interested, doesn't appear to be interested to want to enter into state agreements with just one part. They want a regulatory entity involved. And so I think we wouldn't get very far if the board wasn't a partner in that effort. So that's how it worked the first time. That's my thinking about the discussions to date on the next one. Elena or Sarah, anything you think I missed or you'd like to add?
I need to interrupt because Senator Cummings needs to go, and this is a very important conversation. And so, and is exactly why we have Ina coming in to talk about
Perfect.
the waiver application, and our committee can influence the waiver application. I think that's the short answer. But I'm not wanting to cut the conversation off because I think it's important, but our committee time is over and I want to respect everyone's time. So please keep this on the tip of your mind and we'll come back to it as soon as I can find a spot in our agenda. Thank you. That's good. All
It's
right.
a 3-part series.
We're on to number 3. We said there were 3 parts, but we're not looking at number 3. We're hashing out 1 and 2 again. Okay, this is great. Thank you. Thank you all.
Thank you very much for having us.
Thank you for
All right.
having us.
Take
Thanks.
care. Okay, Nellie,
Bye,
we
everyone.
can